So, but I'm excited always to spend time with faculty to hear ideas, get comments and thoughts from you. So let me go ahead and get started. I really want to answer these two main questions. How can I enhance motor learning for these early skills? And I'll show you how we do that in our program with the range of motion manual muscle test app. And then how can I enhance application and development and develop early clinical reasoning for the students? So we built a bunch of mini games, mini simulations, because one of the comments we were getting from, well, I was giving to my early faculty who are teaching range of motion MMT, we always look at each other in faculty meeting and say, wait, didn't you teach them how to assess range of motion and manual muscle tests? And they're like, yes, of course. And we're like, hey, in ortho, the students don't remember how to do any of it or when to do it. And so everybody's looking at each other like, well, we taught it. And so we decided that there was a half step missing. And that half step was when they were learning these range of motion manual muscle test skills, it would be really nice to give them little games to play that are patient driven, patient contextualized, to help them apply the range of motion manual muscle test type of concepts. So let me take you there for a second, actually. Let me come out of this presentation for a second. If my computer will let me. Hang on one second. There we go. So I opened up PhysioU. And there's a couple things I wanted to show you, some new features, but let me take you through the app first. So as you know, we have added a lot of new apps and a lot of interactive learning components. It's easier for you to sort out which apps you want to see by just choosing these categories above. And so if you go, I just want to see the fundamental skills. Well, here's range of motion MMT, surface anatomy palpation, physical agents, gait, assisted devices, pharmacology. So if we go into the range of motion MMT app, you'll see that we've organized this essentially the same way that we teach it. For example, if you go into the shoulder app, you'll see that there's basic palpation skills. Now, I will sneak in a new palpation app that I think is fabulous that we've just released. But what you have here is basic bony landmarks and soft tissue palpation for all the common structures. And because our class, this class, is tied to our anatomy class, when the students are done dissecting on the shoulder, they are learning about bony and soft tissue palpation on each other in this clinical skills 1 class. So you can see that these are all.
When palpating for the coracoid process, the coracoid process is an attachment for the pectoralis muscles. So
Dan will go ahead and describe how it's palpated, the process of using different bony landmarks and different structures to try to locate the tissue. And then there's basic instructions about, purpose, some cues on how to do it, some associated structures, some potential conditions or impairments that they might look at, and some testing that we might consider. So we're trying to build some connection even early on, because I think this little bit of pre-exposure makes the learning have much better longevity. And so that's how this palpation side of the app works. So you can basically go, I want to look at posterior structures, lateral structures of the shoulder, bony landmarks. We have all these soft tissue structures. And Dan is essentially describing how he would palpate all of these structures. When you move into the actual range of motion section, so one of the things that myself and Dan and Chris, who teaches this class in our program, basically said it would be really nice if before students came to class, they could preview a lot of these lab techniques. Why would we only expose the students to the lab technique that one day they don't know what's coming and they have to take notes and watch it all for the first time and the last time? That's the first time and last time I'm going to demonstrate it. So we decided that it would be useful to organize a bunch of videos of all the techniques that they're going to learn so that they could pre-watch it before class. And I'll show you how we do that. So there is always a little end feel video. So Dan will describe the different end feels. If you go back to a range of motion, you can see then Dan describing in a minute and 50 seconds how he assesses range of motion, including adding the goniometer.
In this position, with the patient lying supine, we're going to abduct the shoulder to 90 degrees, flex the elbow to 90 degrees. And in this position, in this case utilizing a towel, maintain the humerus in a neutral parallel position to the table. This is going to set us up for measuring external rotation at the shoulder. Our landmarks are going to be the olecranon process, and our moving arm will go up to the styloid process of the ulna. Our stationary arm will be from the axis perpendicular to the floor. In this position, I'm going to stabilize at the proximal humerus and allow the patient to externally rotate, looking for any type of rocking or anterior motion that would indicate an end of the patient's available external rotation. In this measure, many times, particularly in patients in throwing sports, you may see range of motion that is well beyond 90 degrees in this position. In that case, you need to maintain this forearm clear of the table to allow to measuring below the level of the table in this direction. So make sure that you're not just measuring the arm hitting the table. In this particular measure, that would I feel an anterior rocking. That would be the end of the range. I can get my goniometer. We're going to go perpendicular to the floor and then measure along this line.
So you can see that our students preview all of these videos at least once before they come to the official lab. There's instructions, the written instructions, and then you have these normal testing position, normal end feel, goniometer landmarks, and then normal ranges of motion from a couple of different sources. Dan also mentioned that he likes to add a few nuggets, a few pearls, keys to reliability. So maintain neutral glenohumeral position throughout the testing position. You can also see here in this example for shoulder flexion, shoulder external rotation also has this, that we have tried to make a connection between function and occupation related to the range of motion assessment or the manual muscle test assessment, because we tend to teach these techniques in isolation, and we really want students to be able to connect those dots to say, why is it, what functional limitation is driving me to assess range of motion of external rotation or range of motion of flexion. So you can see here function and occupation, reaching overhead, obtaining and using supplies for bathing and showering. So there's just this kind of bookmark that we try to help the students make that connection there. So if I go into manual muscle test now, you'll see that we made a special effort to take that movement, flexion, and tie it to the key muscles, because again, they're in gross anatomy or they're fresh out of gross anatomy. We want to make sure that that connection has been made. Once you go into shoulder flexion, you'll see the different grades, grades 0 through 2, grades 3 through 5, and the instructor demonstrating the technique.
With the patient in sideline position, I can now look at gravity minimized testing for shoulder flexion. In this position, you can have a table if you have the ability to do that, to have the arm slide, as we do many of the other tests, but it is very appropriate just to hold the arm. The key factor here is that I have to allow the patient to perform the activity. All I am providing as the tester is the ability to hold or take the weight off of the arm. So in this position, I would palpate the anterior deltoid, ask the patient to actively flex and move their arm forward. As I hold her arm, she's moving it forward. And in that position, I would grade that as a grade 2 for gravity minimized flexion of the shoulder. Instruct the patient once again, holding the arm and supporting it, palpating here. Instruct the patient to flex forward. I feel no motion whatsoever. The patient's unable to move forward, but I do feel a contraction in the anterior deltoid. That would be considered a grade 1. I instruct the patient once again to move forward. I feel no motion whatsoever. The patient's unable to do that.
and I do not feel any contraction of the anterior deltoid muscle, that would be considered a grade 0 for gravity minimized testing of shoulder flexion.
So again, the students have basically observed this. Do you have any comments, James?
Yes, I do. A couple large ones first. The app does not replace you and I as teachers, and so Dan's clinical pearls, I think you need to add your own. I mean, there's a physique attribute and liability I have being a big guy and doing something that a smaller person may not. And so you get to add that to your lecture in class as you go through there. The question is, Mike, with the variations in the accepted normal range of motion from, the orthopedic surgeons, AMA, I think you have a chart in those that lists all the variations and stuff. And then
Yes.
the alternate positions, and that again, David, is students come back from the clinical rotation, say, well, my CI said you do it this way. Well, what we showed you and what your CI showed you is a way to do it. Have the sound gravity eliminated or anti-gravity positioning identified, and then you got to make your decision as you go from there. Not every cardiologist agrees on every intervention for a chest pain person, and so you as a practitioner have that ability to teach your students to learn what you can and be able to integrate that knowledge intelligently. So a question about the students with variations in typical range of motions, Mike, how do you?
Yeah, well, in the ranges of motion, we generally try to apply a few different options, meaning we looked at AMA, AAOS and AMA. If they're the same, they're there. If they're different, we list them as different, and we just agree to disagree, or we just agree to know that there are different sources out there, and it's okay for it to be a little bit different. Now, I think what will be useful for your students is you can agree with all of your students, we're only going to follow AMA or AAOS for the exam, period. The other thing I would add to that is, yesterday, we filmed a bunch of Kendall-based MMT. So initially, we were following Berryman-Reese, which is the textbook we use, and Norkin and White. And as faculty feedback has come back, they've said, hey, we do our grade 0 through 2 positioning a little different because of our textbook. We go in and we film alternate positions. So yesterday, I think we spent about 2.5 hours filming a bunch of Kendall-based techniques. We went through the entire app, determined which of the techniques were different from Kendall, because we know a lot of faculty still use Kendall, and we filmed it. Now we're editing it, and soon it will be added as alternate positions for various manual muscle tests. So that's the power of building this in a digital platform, is we can hear your comments. We can hear your comments, and we can basically modify on the go. We can continue to make this better and better.
The question is like, what's going to be on the test? You tell your students, well, this we're going to use our text of reference,
right,
so for testing. But then the other thing is what's on board exams, and I'm told that board exam questions won't be just that simple. What's this number or whatever? But instead, it has to be referenced 3 times in different sources for it to make them, cutting room floor to be on a board exam question. So it's got to be out there quite frequent, as very obvious for the answer.
I would also say one other thing, and that is the videos. We've reshot this app so many times because Chris, who teaches this class, is extremely particular about following the book and following the rules and doing it consistently. Dan, a clinician of probably over 30 years, has learned to do it how we do a lot of things in the clinic. And so over the years, we have refined it where I think we are quite comfortable to say, this is a pretty darn good starting place. And it is pretty consistent with most of the key textbooks that we use. And what it does for us is it standardizes all of us core instructors. Every instructor who teaches or is part of this class, we follow the same video. So there's very little variance, which reduces the student anxiety, reduces the ambiguity, because they said, well, so-and-so said I'm supposed to reach here and touch here and this landmark and that landmark. So I think that's helped us a lot as well.
The other comment, Mike, functional range of motions with the OT emphasis. Sometimes on some of these things, we've added the functional range of motion kind of mindset with it. And then, Laura, allowing your students to demonstrate it. I mean, that's just how much time do you have in the lab? And then, Eamon,
well,
go
James,
ahead, Mike.
I would just add in that we purposely added this idea of function and occupation. So this is shoulder abduction.
This is your question, Giselle.
Yeah.
In the chat.
We purposely said, you know what, why isn't it that when students get to ortho, they don't realize that when a patient says, I'm having problems with dressing, that they should indeed assess range of motion of abduction, potentially, or a manual muscle test of abduction. And so what we did is we add that to the conversation during the early classes. We say, guys, what kind of things in life that you do need shoulder abduction strength or shoulder abduction range of motion? So we ask them, think about it. What kind of functional or occupational activities do people do? And then we throw a picture up here. Sure enough, there's the abduction, facial grooming, performing personal hygiene, swimming, dressing and undressing, giving hugs. And so all the students, the students like, oh, that totally makes sense. When patients tell me about this functional limitation, then I can then go, I wonder if this particular range of motion or strength is impaired. So that's another piece that we've added in recently, because again, we felt like that was one of the common issues that we saw in the classroom. The other thing that we add, so you've seen palpation, range of motion, manual muscle test, and the neuro screen. The neuro screen, we do this in this early clinical skills class. You can grab this for any class that you need where you do the neuro screen. One of the issues that we were having across the curriculum was in this clinical skills class, the instructor would teach neuro screen a certain way. Then when they got to ortho, they got taught it a certain way. And when they got to neuro, they got it taught it another way. And the students were just getting frustrated. Like, how many ways do you want us to learn this? Could you guys get yourselves organized and decide what is a good way that we could all agree on? So we decided from the neuro side that we were going to follow how they do neuro screen, and essentially filmed all of that here. So you've got upper quarter dermatomes, myotomes, and reflexes. And all of this is standardized across our curriculum. So that's also helped us normalize and homogenize the content. So again, here is your upper quarter and lower quarter neuro screen. I don't know whether this, I'm just curious with the group, whether these are some of the common things that you guys face as well. Any comments about that? Consistency among instructors, as well as consistency of how we do these common techniques across the curriculum. Any comments and thoughts about that? And I'll share screen in a second. I just wanted to see if anybody had anything to say.
The two comments that have kind of like teaching applications, do you allow your students to demonstrate these grades in MMT lab or whatever? Laura asked that. And then again, you kind of touched on it, but the differences between PhysioU and the college textbooks, and you kind of showed how there's a variation there, but you may want to reiterate.
Yeah, so I would just say that related to the common textbooks, initially we tried to choose what we thought was the most logical and the cleanest way. So regardless of which textbooks were being used, we thought this is very clean, it's very organized, and it's very consistent. We filmed all of that. Eventually, we got feedback from faculty basically suggesting that, you know what, I like the way you filmed it. It's just different from the textbooks that we use. So in order to meet that need, we started filming alternate positions. So that you will see in the apps that if the way we do a certain MMT is different from how you do it, there's a good chance that there's an alternate position that we filmed that actually matches the way you do it. And really, by the end of the filming yesterday, we should have covered all variances, which is for better or for worse. I mean, I know I was talking to a number of faculty. They're like, I'm looking at 3 different textbooks for MMT, and they all do something a little bit different. I'm pulling my hair out. We were hoping not to have to do that, but I think in order to support the educators, regardless of what textbook they use, we've filmed that. James, the other thing that you were asking about practice, what was that again?
In lab, do you, and it goes back to like maybe teaching your lab. I mean, do you let Does Chris have them all practice
Absolutely.
the different ones? Yeah,
Yeah.
in each grade and stuff like that. So they watch it on video, they learn it, and then they then have the motor skill component.
Yeah.
So they got the cognitive and then the psychomotor portion of it that you get to do as COVID allows you.
That's right. So what we've done, what we tried to do in these classes that have the motor skills is we basically said, hey, you have your lab handout. In fact, let me show you that real quick. You have, and then I'll show you the simulations in just a second. So you have these video linked lab handouts. And the way that you get to it is if you go to the website, okay, so the main website, under educator, there is a faculty resources. Sorry, I know that's a little bit small. When you click on faculty resources, it will take you to this page where there's a lot of different content for faculty. And if you click on teaching content, it will take you to a bunch of different options. In fact, let me show you how that happens. If I can go here, I'll show you in real life. So if I log into PhysioU.health, let's say, and I go to educator, there's a bunch of faculty resources. Let me make that bigger for you. And in the faculty resources, you'll see that there's teaching content. In teaching content, you'll see that we have created some lab handouts. So for many of the classes that have very, very predictable ways of delivering lab techniques, we've essentially made lab handouts to support faculty. I mean, we were building it anyway. We were just going to share it. So if you look at range of motion MMT and you go to shoulder, you'll see that there's a Word doc as well as a PDF. You can take the Word doc and edit it to your heart's content, but it is essentially the same as this. So all of the students will take this and they know ahead of time, I need to go through and learn these different techniques. So when they click on coracoid process, for example, it takes them directly to the technique and they watch it and they try it on their own. So we just deputize them and say, hey guys, the techniques are there. They're not complicated techniques. Go ahead and click on it, think about it, try it on someone. And when you're done, when we come to lab, we're going to show it again. And this time, because you've seen it all before, I get to add all of these little nuanced things and talk about clinical reasoning and talk about application. So I think that's how I envision actually the future of motor learning is really spread over multiple exposures. It's really graded exposure. They overview it on their own first, give it a go, because this is not hard stuff. And then when we come to class, if they're all separated in pods, we'll demonstrate it or show the video and then talk about different little extra things and really try to create the context for the application of these techniques. So that's what I wanted to show you related to the lab handouts is all of these lab handouts are created for you and available for you to utilize. The Word doc is the exact same thing. It's just now it can be edited by you, but everything's done for you. And while I'm there, let me add one other feature that we've just released for faculty only. Here, as you can see in the sidebar, we have a educator resource, meaning anytime you want this video in your PowerPoint or in your lab handout, you can click on that, copy page title with link. So if I go back to, let's say, this Google Doc and I create a new document here, you'll be able to see that. Let me make that bigger. I'm just going to Command V and there it is. The title of the technique, it's already hyperlinked. Okay, so there's already a hyperlink there. And if I go back to the app itself, I can actually copy thumbnail image, go back to my new document, Command V, and now you have a picture of the technique, which is a little bit big here. So you can just make that a little bit smaller. You have the picture of the technique and the technique, video linked and title, all done. So anytime you're presenting your lectures, you click on that link, it will open PhysioU because you all have full access to PhysioU and these videos will play. When your students click on this, they log into PhysioU, all of these videos will play. So you have the entire PhysioU video library at your disposal. And so that is one of the things we just added is educator resources. Let me show you how we actually use the simulations we've just released. So if you look back to the apps, let me sort us to fundamental skills. Actually, I'm going to go to simulations. You'll see that there are a bunch of range of motion MMT sims. This has been designed because we knew that students needed a safe and fun place to apply their knowledge. So here is shoulder. It's a 10-minute game. The students go through, they identify landmarks, they practice taking readings, they review range of motion normative values. And we essentially start with a patient talking about, hey, you know what, I'm having trouble lifting my arm up to the steering wheel. How am I supposed to drive? It's really been hard for me to wash my hair. So we asked the student, hey, based on the things that they can't do, what kind of range of motion do you think you should assess? So we say, well, I think we should assess shoulder flexion. Great, keep going. Let's take a look at how he moves, right? Think about this as a half step beyond what we've just taught them, creating the little bit of a clinical scenario. It's a simple clinical scenario. It's not tied to any pathology, really. And then we ask, hey, drag a box from the right to the correct location on the goniometer. Here's the stationary arm. That should be the mid-axillary line. Let's go to the lateral epicondyle for the movement arm. Let's go to, I think, let's see. Perfect, greater tubercle. Now, before you place the goniometer on the patient's arm, can you now place the axis of rotation in the right location? Can you put the movement arm in the right location? Can you put the stationary arm in the right location? And then we submit. So think about how this is taking what they've learned once in lab and giving them a chance to actually apply this knowledge in a kind of fun clinical environment. The other thing that I would say, hang on one second. The other thing that I would say is when you add this interaction, we say, hey, can you line up the goniometer the way that you would put it? So there it is. We submit it. Great. And now you have to read the darn thing because that's half the battle. So the students stare at this, wonder which number they're supposed to follow. They make their call. Let's say, looks like 75, let's say. We ask them based on the norm, what is the normal range? I'm going to go with, we'll see. And then here is your review. When they're done, this score, they can either hit the button for review. If they hit review, they can look at all the questions, what they got wrong and what they got right. The other thing they can do now is they can download a learning report. I have them submit this to us. So they download the learning report. I can now go to my Finder and you will be able to now see. So let's go to downloads. This certificate is what they turn into me. Here's the simulation. Here's my name. This is the date I did it. This is the highest score. I always tell them, I'm taking your highest score. You can play it until you get it right. And I get to see how many times they did it. Basically, we take the last 5 times they did it. And then we know the score and the amount of time they spent on this game. So that's one of the ways that you can create accountability. Believe me, the moment we released this type of learning, we've had over 11,000 completed learning experiences from students in the span of like 3 or 4, like about a month. So students are eager to play with this type of content to kind of apply their knowledge and really get a sense of whether they know what they're doing. So we have students turn this in and we give them very minor points for doing this. Usually what we tell the students to do is you can take you can basically take that particular game, let's say shoulder A, and you can just take this hyperlink and paste that, copy and paste it into your syllabus. So you're like, hey, in this week, I want you to play a shoulder game. There's a range of motion game, there's an MMT game. Please play that and turn it in. Let me take a second, actually, since we are pretty much at the end of this. Any comments? And by the way, guys, I'm not in a rush. I'm here to answer questions and to get your feedback and your thoughts. But I did want to honor your time. Any thoughts or comments related to what I've just been able to show you?
There are a couple in the chat, Mike.
Sure.
If those folks want to unmute and ask it, or if they want me to do it, I can still verbally cue you to their question.
Sure. Does anybody want to mention their comment or question? I can stop.
People are tired of hearing me talk.
And I can pull up the chat as well.
Yeah, the one question is kind of more of a kind of a procedural thing. If they're in their second year of a 2-year subscription, will the new information be available to those folks? I know the answer, but I need you to announce it.
Yeah. So the way we build things is we just keep adding cool stuff based on what I think faculty are telling me that they need, or selfishly how it helps my own students and how it helps my own teaching. And so it doesn't matter when a student has purchased a subscription for this, as long as they have access to everything new that we put out that is related to the web app. So, the students have access to all of this. And just as a teaser for the webinars that are coming up, because I wanted to make these short and sweet and tied directly to a certain app, there is a ton of great acute care, MicroLearning. I mean, some of the little things that the students can use to engage their mind and apply their knowledge, it's so powerful. So there's a ton for acute care. There's some really cool ones I'm talking about next week for physical agents, application on patients. There's a bunch of really cool orthopedic simulations, which I'll talk about, neuro simulations. So if you think about where we're headed with PhysioU and our other apps that we're building, we're really carefully thinking about what content area really benefits from really good video, and also some of the content areas that could benefit from clinical reasoning development, because many of our apps are tied to clinical patterns. And then we're really trying to engage the students and help them play with the knowledge, apply the knowledge in a safe, fun environment. And I think these are really critical elements, especially what I'm seeing this year with my students is instead of having 2 or 3 that are struggling, there's 12. And I'm not sure whether part of it is just inherent stress of the way things are going with COVID, but I think that giving them different ways to be exposed to motor learning, giving them a longer ramp up, right? You think about first, look at the lab handout and explore them on your own first. When you get to lab, we're going to practice them, but don't worry, because all of these videos you have in your pocket. And when you now go to practice on your own, you have the same videos. And when they get to clinic, they have the same videos. Think about the power of this resource that follows the student throughout the entire curriculum, and how they can continue to reuse a lot of these knowledge checks or these little games as ways to re-engage with the knowledge. So we're building, just so you know, all of these mini games that we've created. We're creating what we're using as a preclinical competency, meaning before their big set of clinicals, we are going to have the students go through and play selections from all of these mini games that will allow you to actually, they're going to have to study it all, but they're going to play through these different selected questions and interactions and orthopedic evaluations, neuro stuff. They're going to play through all of those and have to pass that to move on to clinic. So that's what we're doing at APU. We tried it last year. We got good feedback, and we're refining it and doing it again this year. That eventually will be available to you, to your ClinEd team, as a way to help students really apply the knowledge and actually re-engage with knowledge that they've learned over the last year and a half or so. Any other comments, questions? I'd like to just open it up for thoughts.
All right, Mike, we're gonna kind of see where the rubber meets the road. If you take a look at Tamara's comment in the chat, and
yes,
it's kind of nice and fun, and entertaining, but have you seen outcomes improve in your ortho courses since you've been using this? And maybe I'll just say, Tamara, not even just in your class, but even in clinical, does your ACE or whoever, DCE, whatever it is now, your clinical coordinator folk see better scores or reports in the clinical rotations of orthopedics
so
for your students?
I can, yesterday I spent about an hour and a half with a young professor at a nearby university talking about my entire ortho curriculum and how I apply all these things. I will tell you that it is very hard to measure. It is very hard to measure what they will look like when they finally get to the clinic. But I will tell you that we do these mentored evaluations, and we do these mentored evaluations where one student is doing a full evaluation on a patient, a fake patient. That patient is actually a fellow. It's one of my alumni who's residency and fellowship trained. And when we met after the first mentored evals, this is the end of their first year. Ortho 1 is in fall of their first year. They start in spring and they end the year in fall. We were shocked at how good they were doing their first real full evaluation. Now, we did a lot of practice ones leading up to the mentored evals. I can tell you that I've been using the Ortho app for the last 4 or 5 years. And the biggest outcome that we assess, I mean, the grades are the grades. The written exam, I think, is not predictive of how they will perform in the clinic. But the mentored evals and how they perform as young clinicians is probably quite predictive. We get lots of very good feedback about our students related to ortho from the CIs. And I'll tell you that most of us mentors, there's about 12 of us who come in for that mentor eval day. We are shocked, flabbergasted at how good they are, partly because we play with them in the sandbox a lot. Meaning there isn't a week, like let's say shoulder week or lumbar week takes 2 or 3 weeks to teach. We pause. We do a bunch of cases. We allow them to play these really simple back pain cases and different categories from the guidelines. We make all of these simple cases. They play them out. They try it out. We discuss it. And then they come to mentored evals about 3 weeks later. The way that they perform in mentored evals is shockingly good. We don't wait to the end of ortho to ask them to perform evals. We're doing evals so much that they can't help that by the time they get to mentored evals, they're actually pretty decent and ready to learn from the feedback of the mentor. And so to be honest, I would say very hard to objectively measure, but we are very pleased about what we are seeing as these students are beginning to perform evaluations and develop their clinical reasoning. Like selfishly, when I talk about the orthopedic app, that app is not just a library of techniques. That app connects common movement faults, the way the patient presents, the special test, and the common impairments. It talks about differential diagnosis. There's so many elements that I'll talk about in the orthopedic webinar that really help the students connect all of these dots that have actually been delivered at different time points throughout the curriculum. It's very powerful. I'm happy to share that with you, Laura, or Tamara. But yes, I would say what we've seen is reduced anxiety. We did some outcome studies, survey studies of the students, and they basically say, when I can see my techniques ahead of time, and I know I have these techniques in my pocket, it reduces my anxiety in lab. That's something that they told us in the survey. They've also mentioned in the survey that it helps them with their clinical reasoning, because I think there's a lot of like half steps in the apps that allow us to connect to content either in reverse, like, hey, remember your physical agents. This would be really relevant for your frozen shoulder patient. Or, hey, remember TheraX. Oh, you haven't learned TheraX yet, but actually I can show you some common TheraX in the app. And they'll be like, oh, of course, pendulums. I've seen that before. That makes sense while I'm trying to restore mobility for an irritable frozen shoulder. Like even if we haven't taught them the Therex yet, I allude to it because you can access previously known knowledge, or you can put a bookmark. You basically tie off the loose end instead of saying, well, you'll get to that loose end and maybe we'll tie it off and make the connection later, which often we don't. And so that's what I would say about that. Any other comments? Any other comments or questions about the range of motion MMT app or how to apply it?
One quick comment. Again, I'll say, you mentioned how there's consistency through the program because they have it and they can go back and look at MMT and palpation and, you know, say in their ortho clinical track or neuro stuff. They also take this to the clinic with them, you know,
Right.
and that's the beauty too. They go, crap, what's that, you know, up and go test, or what's the
timed up and go test?
Yeah, what's a Romberg test? God, I forget that or something. And that's just such a valuable thing. These guys have this in their phone or some other means that they can carry with them in the clinic too.
Yeah. And for those of you who are still here, let me just give you a quick glimpse, because I know a lot of faculty who teach this course, they teach it tied to surface anatomy palpation. So this app we just released, this professor is an orthopedic specialist, but she's also an artist. And so all of these different bony landmarks and soft tissue palpations, she has essentially painted them onto the patient. So when you're in the cervical spine and you're looking at anterolateral soft tissue, you can look at the structure. So here's the structure with some basic instructions, or here is the video.
The sternocleidomastoid muscle creates neck flexion when operating bilaterally, and it creates contralateral rotation and ipsilateral side bending. It's very prominent on the anterior part of the neck, and you can follow its margins down to the clavicular head here, which is quite broad, and then the sternal head, which is much smaller, that attaches to the manubrium.
So you now have a really useful resource for helping students become really good with soft tissue or surface anatomy palpation. And this covers all the body regions. It covers nerve entrapments, soft tissue, bony. So this app will be a great addition if you're trying to level up the palpation skills for your students. And remember, the cool part about this, the students can almost do this asynchronously. It's just videos that they can watch and learn from that you can apply that can enhance your classroom. So this app is actually a really, really cool app. We had the professor come out, she filmed in our studio, and a lot of this, it's just phenomenal that she likes to draw as well as has the skill to talk about structures and nerve entrapments, muscles, and bones. So this is another one that I think will be useful for those of you who are kind of teaching in this area. This is that surface anatomy palpation app that is down here. Any other comments or thoughts? Let's see. It's like a live living netters. Yeah, it's so, isn't it cool, Christina?
And you don't smell like formaldehyde when you're done.
Yes, absolutely. So if you have any other questions or comments, or ever want to just talk more about how to integrate these different things into your classroom, James and I are always available. Please feel free to reach out to me at mike@physiou.com. I'll just type that in the chat. So mike@physiou.com. And know that you as faculty have full access to all of these apps. I mean, we built this as a gift to ourselves who are teaching in the trenches with you, and to all of our colleagues. Like, we're just like, we shouldn't have to reinvent the wheel. If we could just film all the great things that faculty need, then everybody benefits. The faculty benefit, the students benefit. you should see the wound care games that we're building. Incredible. It's going to change the way our students do on the board exams related to integumentary. So there's a lot of really cool stuff that's coming. I hope this has been useful for you. And just know that next week, I'll be talking about the physical agents, Sims, and the physical agents app and how we utilize it in the classroom. All right. Take care, everybody. Yeah, we've come a long ways from CDs that we were given back in the day. Looking forward to the wound care games. Yep, there's some amazing wound care games. There's some really, actually, the neuro stuff. Neuroanatomy. We have a 3D neuroanatomy app that's designed for learning for rehab professionals that we're working on. Like the Hunger Games, Laura says. Yes, guys, thank you so much for joining us. I'm glad we had a chance to connect. And James and I will be here for a few minutes. If anybody want to just stay back and chat, feel free. But thank you again, and hope you guys have a great weekend. Yeah, any comments? Anybody else want to mention anything?
First off, Mike, a number of things. I'm glad I finally know Dan's name.
Yeah, Dan.
I've called him Jim, John, Joe. Now I get to call him Dan. A funny thing, just yesterday, we learned that we are not allowed to let the students leave after they finish a final exam. We need to be keeping the students in class for the whole 4 hours.
Wow.
Wow, yeah, right. Because they've paid for 4 hours, so we have to give them 4 hours. But
wow. Okay.
Yeah, right. So much for competency-based education.
Right.
However, these simulation games are a perfect way. If they are sitting at a computer and just finished taking an online test, we can have them, okay, you're sitting there, go to these games. Last semester, you learned physical agents. Oh, good. Go through these games. Let's have you reinforce what you learned last semester, because you're about to go out to the clinic. And the fact that I didn't even realize you folks had certificates for this.
Yep.
So, and the concept of repeating it until they get it right, that everybody at their own pace. This is a built-in time filler, if you will. However, it takes it a positive spin on something that seemed kind of punitive. What do you mean you're letting the students out early? Well, they took a test and they're finished. So yeah. I love the idea of this kind of module, an individualized module that's not required. Because
that's right. And make learning fun.
And make it fun. So we, particularly for those folks who are good test takers, okay, I don't want to penalize them. But here's something fun and very helpful for you. So thank you for providing something that is very relevant. And like I said, just yesterday we found out, oh yeah, you can't be letting these students out. So
wow, yeah. I mean, I think that is definitely one way to do it. We have a bunch of, when you think about simulations and games, you have to think of them as two different types. Some are very small, short and sweet, and some are long and develop clinical reasoning in a much more, because the longer the story and the narrative and the more decision-making that occurs, the more fatiguing and challenging they are. But yet it allows you actually to tease out elements of clinical reasoning much better than some of these short games. And I think there's a place for both. There will be some very amazing longer macro sims. There will be some of our ortho sims are pretty good. They're already 30 to 40 minutes long. And we're building an entire set right now of clinical practice guideline based mini games, mini sims for orthopedics. If you haven't played the first set that we've already created, they are phenomenal. I've built them purposely to be formative. So the students can enjoy going through these mini games, these rehab foundations. These four cover the main 4 ICF categories: mobility deficit, movement coordination impairment, radiating pain, and muscle power deficit. That was my first experiment. I like them so much because they each cover, if you look at the educator info, it tells you exactly what clinical practice guideline it comes from. There's a link to that guideline. There's a link to the decision tree, right? You can go directly to the decision tree, and you can see almost every single question element that is in this game is laid out here. When they play it, I used this on the first day of ortho. They had no idea what I was going to give them and what this stuff is. But once they played through it, they're like, wow, I just kind of understood how a person with hip OA looks and what kind of testing I would do and what kind of treatment makes sense for mobility deficit. I use it as a way to set the foundation. Somewhere between now and early 2022, we will have another 20 of these. Every single clinical practice guideline condition will be turned into a formative game that our students can play as a way to expose themselves to guideline-based content. I mean, it is game changing, I believe, in the way that we teach our students. We don't have to deliver all the content and then hope that we can pull it all together. I think when we create these types of mini games, you can create scaffolds in which now the details in which we teach over the span of two semesters of ortho, they now fill the scaffolds. They add details to these pre-developed scaffolds, but we can do it in a fun way. So that's kind of my secret little project for the rest of this year, is about 20 other clinical practice guideline mini games that you do not have to worry at all about philosophy. It is purely from the guidelines. If they play through this game, they will understand the basic testing, the basic intervention strategy, the basic clinical pattern of signs and symptoms. All of it will be done just by playing. It's phenomenal to be a part of this creation process with our team. So I hope that gives you a glimpse at where I'm headed for ortho, because ortho is so big and so messy that it can, at the end of 2 semesters, you could have a hot mess on your hands. But if you do it right, you can have these phenomenal young clinicians that understand guideline-based practice. So I'm really excited about it. Any other comments? Any other thoughts or comments? Well, great, guys. Thank you so much for being a part of this. I hope you guys have a great rest of the semester, and look forward to seeing you again in any one of our other small seminars and webinars. I hope these little short, useful ones directly tied to a content area are useful for you. I know that there's a lot of stuff in PhysioU, and each individual app can make significant impact into multiple courses across the curriculum. So thanks, Tamara, for all of your great comments, to Amon as well, and to everybody, Kyla. Thank you guys, Barbara, for your kind words, and Michelle as well. So have a great afternoon, everybody, and hope you guys, stay healthy and stay happy. It's been a tough year even for me with all of this stuff. I really miss seeing the smiling faces of my students. So have a great one, everybody.